Welcome, everyone. Thank you for tuning in to today's edition of Breaking Down Lung Cancer. We're going to be discussing prevention, diagnosis, and treatment strategies. I am Fiona Evans. I am the Director of Patient Advocacy here at Massive Bio, and I'm joined today by Dr. Luis Reyes. Welcome, and thank you for joining us.
Thank you very much for the invitation. It's a pleasure to share with you today, and looking forward for answering your question.
Excellent. Could you give us a little introduction, a background about you and what you do?
Yeah, my name is Luis Reyes. I am the medical director at Memorial Cancer Institute. It's part of the Memorial Healthcare System. The public healthcare system here in South Florida is the third largest in the country. We have 6 hospitals in Broward County. And I'm also a professor at Florida Atlantic University and Florida International University. I do mainly lung cancer as a medical oncologist for the last 23 years. And we do also a lot of research here in the areas of lung cancer, liquid biopsies, and healthcare and equity.
Great. Well, thank you. You're very busy, so we appreciate your time today. So we're going to jump right in. What are the primary risk factors for developing lung cancer? And are there any lesser known risk factors that people should be aware of?
Yeah, that's a very important question because, you know, we have spent our lives trying to cure lung cancer, spending millions and billions of dollars. But your question is very important. At the end of the day, if 80% of our patients have never smoked, maybe they will not be patients here. You know, that's why we can address right away most of these lung cancer problems if we still go back to the old statement that the stop smoking, you know, or quit smoking is the best, probably the best way to fight lung cancer, because it will be verification, you know. That's still the largest risk factor. And most of the lung cancer prevalence, the smoking prevalence, has been going down, first in males, then in females. We're only worried about the young generation, that especially young ladies are still smoking. And now we are a little bit worried, but none of our lung cancer organizations, I think, are supporting vaping, because we used to start to smoke at 18 when we can buy cigarettes. These kids are smoking, vaping since they are 12 or 13, so we don't have an idea what is going to happen with them, especially they have 5 extra years of vaping, you know, before they become adults.
Right.
That's what we don't know about vaping, before you ask me. But we don't think it's safe until, because remember, for lung cancer to develop, you need to be smoking for many years.
Right.
Because I want to answer the question regarding vaping in 20 or 30 years, but I don't want to find 20, 30 years later that there is 1 million people that was vaping and it's too late for them to save them, no?
Exactly, yeah.
Yeah, another risk factor is we have around 30,000 Americans that are non-smoker, and it's very frustrating for them to develop lung cancer because they said, I didn't think anything wrong, you know.
Right.
There's still a lot of stigma for people that smoke. And in these 30,000 people, we think that maybe exposure to radon gas, radon gas lives in the soil. You know, if you have spent time in a basement in the Northeast United States, maybe you are more exposed. It's very hard to prove. And now, as much as I know, the builders play safe, checking radon gas when they build the houses, so it's not supposed to happen anymore, I hope. Asbestos is another risk factor, but you know, for the last 30 or 40 years, we are not supposed to be exposed to asbestos any longer because the construction codes are very strict.
Right.
And also occupational hazards, you know, 40 years ago, our firefighters and rooftop workers, welders, shipyard workers were exposed to asbestos, and now it's not supposed to happen anymore. So I hope that with this one, the asbestos effect goes down, and we can even, you know, get rid of mesothelioma, that is another cancer caused by asbestos. And then we have a group of lung cancers that are unknown. And very, very interesting because, for example, genetics, there is no genetic lung cancer that we have been able to prove. We have suspicions about a gene called EFR 790, because we have found that is a gene that appears in patients on treatment, but we have found young individuals that carry the gene and they don't even have lung cancer. But that's for the people that is watching. Until today, we haven't been able to prove that the lung cancer is hereditary. So don't worry about your kids, your loved ones. There is not like a genetic risk or genetic test that can prove that it's hereditary or not. Not yet.
Okay, well, that's one good thing, right?
Yeah, but finally, the most worrisome thing is that okay, so if tobacco exposure can cause, because of the fumes, can cause lung cancer, how about contamination, pollution, you know? So this year was a very important year because the people from UK, Dr. Charlie Swanton, one of the most bright lung cancer experts in the world, finally showed that the exposure of a certain amount of pollution is linked with the developing of lung cancer. And that is very worrisome for us because some cities, that amount of pollution is probably already present in 30, 40, 50% of the cities of the world. So that is maybe some of the non-smokers can get lung cancer from pollution. This is something that we need to be working very hard to issue recommendations from our own government.
Right. Yeah, that's very important. Is there anything that individuals can do to reduce their risk of developing lung cancer, especially if they have a history of smoking or exposure to environmental toxins?
Yeah, well, other than this, quit smoking as soon as possible. Your quitting smoking doesn't give you safety, unfortunately, because you need to quit smoking and be tobacco free for 20, 25 years to decrease your chances. You know, it's not like the next year or the next day you're fine, you're safe. That's why as soon as possible, that's the best advice to quit. And then I already mentioned all of these other risk factors, and it's better not to be exposed to any of them. And so for people that already have smoked, remember that we have the lung cancer screening now available worldwide. Most of the governments of the world already agree with that. The implementation is poor. You know, United States, we're supposed to screen 15 million people that used to smoke. We barely screen less than 1 million. So we are very, very short. And we need your don't wait for your primary care to send you for a CAT scan for lung screening once a year. If you are already being a former smoker, it's better that the patients start to empower themselves and say, hey, you know, I need a CAT scan. I used to smoke. I want to check myself once a year because I don't want to find lung cancer stage 4. That unfortunately, even today, a large number of lung cancer are diagnosed stage 4. So, and we cannot cure them. That's why it's important that we diagnose them stage 1, thanks to this screening. And the most important one is, you know, if you're a 50-year-old or above and you have smoked at least for 20 years, you need to get once a year a CAT scan. The United States is covered by Medicare and insurance.
Oh, that's great news. Yeah. So early detection is key. You want to get your screenings in, as you know, especially if you are a smoker. And I'm gonna move on to my next question here. Could you explain the difference between types of lung cancer and how they vary in terms of symptoms, progression, and treatment options?
Yeah, we have a lot of lung cancer in the United States, 235,000 new patients a year. That's a lot of people, unfortunately. And the patients get frustrated because the classification of lung cancer based on tissue, what we call histology, is very simple, like you either have small cell lung cancer or you have non-small cell lung cancer, two types.
Mhm.
Okay, and then the treatment for small cell is different. That's the cancer that is you have a higher incidence of tobacco smoking people, the small cell, and it's unfortunately very lethal, and usually it's behind in new development. The small cell for some reason has been escaping us from a lot of developments, to the point that for the non-small cells that are close to 90% of the population, we even have now oral agents, pills. For small cells, we don't have a pill yet, so that's why it's very frustrating for the patients to learn that they have lung cancer and the one that they got is a small cell. The non-small cell, the most common one, that is 87% of the population, because it's less smoking than the small cell actually is shrinking and the non-small cell is growing in prevalence. It can only be divided in another 3 or 4 groups, and that is why there is not a lot of science there. Today, we do now molecular classification. We don't classify the lung cancers by tissue. We classify by genetic analysis.
Mhm.
And we have learned that now there is many types of lung cancer. Where we used to think there is 2 big groups and 4 subgroups that I mentioned.
Mhm.
Now there is more than 40 or 50 groups, and the treatment is going to be different from each of them, mainly depending on the genetic aberration that we find. For example, the most popular in the world is a genetic aberration in a gene called EGFR. And fortunately, 12% of Americans have this genetic aberration when they have lung cancer. Unfortunately, and then the good news is that we have a pill, an oral agent, that is the frontline therapy. Unfortunately, don't cure a lot of people, but it's much better because now we can keep patients 2, 3, 4 years with this oral agent instead to start palliative chemotherapy.
Excellent. That's good. So for patients that have been diagnosed with lung cancer, it's important for them to get that biomarker genetic testing.
Yeah, that's extremely important question, because in United States that we already have identified 10 different oral agents approved for lung cancer. That's a lot of oral agents. 10 pills that we have already available and FDA approved. Only 50% of the Americans get tested.
Yeah.
And less than that to receive these 10 oral agents. So it's not like we don't have the science. Now that we have the science, it's more frustrating for me that the patients don't have access in the best country of the world, the one that have more resources than any other country. So that's why there's a lot that we need to do, and that's why I love these programs, because, as I said, empowering the patients need to help. I love when the patient comes to my office and I said, okay, this is my name, you already got the news of the lung cancer, we're going to start and talk about your treatment. And the first thing that the patient or the family said, yes, Dr. Rice, but are you going to do my molecular testing? I do my genomic testing. I said, for sure. That's the most important thing. That's what we call precision medicine. If you heard about the word in the street now, precision medicine, that's amazing. We're going to do a genetic testing, and based on the gene that your lung cancer carries, and it's probably the one that generates the lung cancer, we are going to give you, hopefully, an oral agent. And if we don't give you an oral agent, we have immunotherapy, we have chemotherapy, we have other means to treat it. But it makes a big difference to give you this personalized treatment. You're going to be much longer than if I give you empirical chemotherapy that we used to do 20 years ago, that everybody lived the same, and very short survival. Now with the oral agents, we have patients alive 8, 9, 10 years. That was unheard in lung cancer before.
Yes, that's excellent. So everybody should get molecular biomarker genetic testing if they're diagnosed with lung cancer and many other cancers.
In lung cancer, it's important. Sorry for interruption, because
that's okay.
It's a standard of care now.
Good. So everybody should be getting that.
Yeah, because that's very important differentiation. I think in United States, I dream with the day that is a patient's right for any cancer patient to have molecular testing. And I think little by little, we're educating our legislatures. So one day, somebody will give a law for this. And we, so far, we have the sympathies of both parties. Okay, this is an opportunity for
Yeah.
everybody to agree. But is the reason why it's not, the law is not given yet is because it's really mandatory for 100% of lung cancers, but not 100% of the colon, breast, and other cancers yet.
Right.
So that is why we cannot still push for everybody. But for lung cancer, yes, I already tell you, have 10 genes for what we have many oral agents that can keep you alive for years or maybe cure you. So this opportunity cannot be missed because otherwise the patient is going to suffer the lack of proper therapy if we don't do that.
Right. Yeah, it's very, very important. Thank you for
Yeah.
pointing that out.
The other thing is also in the United States, we're very lucky that we have what is called liquid biopsies,
Right.
meaning that the gene analysis, the genetic analysis that you need is normally done in the tissue. But sometimes, you know, the tissue is not enough because when the pathology finish saying, oh, this is a lung cancer, it's small cell or non-small cell, he
Right.
has all the tissue. So sometimes there is not enough tissue. That's why doing a simple blood draw in the patient, we have the technology, not only in the United States, but all over the world, to isolate tumor DNA from the tumor, and do the genetic analysis in this DNA of the tumor. So it means in the United States, we have a second opportunity to do the genetic analysis. If we cannot do in the tissue, we should do in the liquid. And because the liquid is so fast, you get a result in 8 or 9 days instead of 30 days with the tissue. Many of us are doing the liquid in everybody because we can have an answer soon. So the patient doesn't have to wait 3 or 4 weeks to know what is your right therapy, because the patient already wants therapy today when he needs you. He already has been waiting months for the diagnosis. So that is why it's important also to remember the public. You have the opportunity to do a liquid biopsy. It's covered by many payers and Medicare, and that is why don't miss that opportunity. And if you can have both the liquid and the tissue genomic analysis, because we don't have any company that we can say, oh, this is the perfect one, you don't need anything else, that increases your chances of success.
Absolutely. Can you talk about the various stages of lung cancer and how the treatment approach differs based on what stage of cancer the patient has?
Yeah, in general, we have what we call early stage lung cancers. These are the ones that we can take a patient for surgery, get rid of the tumor. But because there is always some residual disease after surgery, we give them now, thanks to the genetic analysis, we can give a pill, we can give immunotherapy, or we can give chemotherapy, yeah? Or a combination of 2 or 3. This is very important because we're already doing surgeries for the last 40 or 50 years, and not everybody that goes to surgery gets cured. That is in all the cancers, not only lung cancer. So that's why the genomic analysis now, it moved now to early stages, because we already have proved that after the surgery, we'll give you chemo for a short time, 4 times, 4 cycles. And then if you have a genetic aberration that we can target the patient, for example, with the EFR, the most popular gene, we give you a pill for 3, 4, or 5 years that can protect you in 50% of the time to develop lung cancer again, or to have a recurrence of your lung cancer. That's why for all of these early stages of lung cancer that we call them stage 1, 2, and 3, that is very important to do the surgery first. We still need surgeries, and then give your chemo and then thanks to the genetic analysis, you can get a pill or something what we call immunotherapy. That is an infusion that we give you to strengthen your immune system to try to avoid the recurrence of the cancer, because it will kill the cancer whatever is in your body. And then, unfortunately, we have the advanced stages. No, the patients with advanced stages are the ones that cannot be operated. And of course, all the patients with metastatic disease, that there are a lot in America, you'll be surprised that more than 30 or 40% of the lung cancer patients are still diagnosed in advanced disease because you don't feel anything until it's too late. So all of these patients with advanced disease are going to go for the genetic analysis and they get the oral agent, the immunotherapy or the chemotherapy from the beginning because there is no chance for them to have surgery, you know. And sometimes we use the other modality, the radiation therapy, to help in some cases that are early. No, for example, you did your surgery, there was some residual tumor in the age of the surgery. So I can use radiation there. And in advanced stages, we also use radiation to control pain or to control the tumor. If the tumor is resistant, he doesn't want to die with our oral agents or with the chemo, we use radiation to help us to control. That's why in general, for the public, you can classify in early stage or advanced stage.
Got it. Are there any recent breakthroughs in understanding the genetic aspects of lung cancer that have influenced treatment decisions? I know you mentioned there's lots of genes that have been identified, but anything else that you want to mention?
Maybe this time it's important to talk a little bit about immunotherapy. In lung cancer, we are very blessed. Until 2010, practically, we only used chemotherapy. And the median survival, so half of the patients used to survive 1 year only. And the other half used to die earlier or later. Less than 5% used to get cured. After 2010, we started to discover the oral agents, the pills, but also we start to develop immunotherapy. Immunotherapy is not easy to understand because it's not the vaccine, it's not the COVID vaccine, and everybody's an expert now. It's not a vaccine. Unfortunately, vaccines don't work for lung cancer. But we can say this, like, the reason why you develop lung cancer, like any other cancer, is because your immune system is not working very well against that cancer. Your immune system may be working very well. If you get a respiratory infection today, you're not going to die. Your immune system is going to protect you. But for some reason, that cancer is growing for months, and your immune system thinks that the cancer is friendly, so it's not attacking the cancer. Yeah, that's very interesting in lung cancer. The lung cancer mimics friendly tissues. And it's totally different, for example, from melanoma. In the case of melanoma, your immune system attacks with fears, very fiercely, the melanoma. And you can see when you pull the melanoma in the surgeries, it's full of T cells from the patient that are trying to destroy the melanoma unsuccessfully. No? That's why melanoma wins the war. In lung cancer, no. In lung cancer, it seems like our T cells, defense cells, think that the lung cancer is friendly and they don't attack it. But there is a break. There is a break in the immune system. And we thought that we have discovered the break. We have discovered what is the receptor, and it's very popular, called PD-L1. And that receptor is the one responsible of the break, because the cancer, when he arrives, it stimulates the receptor that breaks the immune system, that puts the break in the immune system. So what we do now is we have many IV, intravenous agents, immunotherapy, we can say proteins that we use, antibodies. And these antibodies work in that receptor PD-L1 and release the immune system. And releasing the immune system, your own immune system notices that, oh, there is a guy here that is not friendly, that we didn't see before, and now he attacks. And this is amazing because we prove this in metastatic patients. Because it sounds very theoretical, you know, very like a fantasy. How do you really know, how you're sure that the immune system is killing and not the chemo?
Right.
No, unfortunately, in metastatic patients, we saw how giving these antibodies, these proteins, the immune system gets stimulated, and now the patient that was not attacking the tumor, their own immune system is destroying the tumor, disappearing the tumor. With immunotherapy, we can cure now 20% of the metastatic patients. So that's amazing. So
that is amazing.
With chemo, used to cure 5%. With immunotherapy, we can cure 20%, despite the fact that they were metastatic patients. Okay,
Wow.
I guess we need to learn how to make this more efficacious, no? We
Right.
still have not learned how to make it 100% successful. It's only 20% successful to cure people, but has increased the survival of the lung cancer patients to 2 or 3 years in compared with 1 year of chemotherapy. So that's what we do. If your genetic profile don't make you qualify for one of these oral agents, we give you the immunotherapy, and we are working very hard to try to improve the immunotherapy. We try to learn why it works in some patients and other patients don't work. Maybe there are some, like the pills, different types of immunotherapies. Instead to use only one, in the future, hopefully we can have 5 different types as we have 10 pills. So that's why it's a very exciting area for us. But the oral therapy, what we call target therapy, the pills, and the immunotherapy are the 2 most amazing developments in the last 10 years in the area of lung cancer. And as you probably know, in many other areas of other cancers that benefit from these 2 technologies.
Yeah, absolutely. That's amazing. Truly amazing. Uh, so what are the typical diagnostic procedures used to confirm lung cancer, and how have these evolved over time?
Yeah, the typical procedure is, we use the CAT scan that shows in your lung that there is a mass. Then we go for the PET scan that more than draw a picture, the PET scan tells you if that mass, that lesion that we see in your lung that is not supposed to be there is benign or malignant, maybe benign. Once the PET scan says that the lesion is malignant, then we do a biopsy. Biopsies are very popular. We do bronchoscopies, no, to the pipes, or we do outside needle biopsies to the lung, to the chest wall, reaching the lung. So by these 2, we do the diagnosis. No, so that's been a standard of care for many, many years, and these are very low risk. There are not really too many complications with these technologies nowadays.
Got it. Okay. So, I know we have talked about research and what that's done, over time here. But are there any more exciting areas of research or innovation that are geared towards lung cancer treatment and prevention that we can look forward to coming, in the coming years?
Yes, because for example, remember we have two main treatments, no? The oral agents, the pills, and the immunotherapy. But our immunotherapy, I told you, only cures 20% of the patients because we need to make it better. We need to discover what's the trick with the immune system. Because what happened is, after this amazing response of the immune system that was with a break, for some reason, the tumor, that is a very smart guy, after 15 months, it becomes resistant again. So the tumor shuts down the immune system that was working very well against him, and then the immunotherapy doesn't work. So now we're working in very exciting technologies to try to either enhance this response, so hopefully the tumor will not become resistant at 15 months. So with immunotherapy, now we give some shots, like boosters of immunotherapy, to try to help to increase the response. And the most exciting thing that happened in lung cancer and probably most of the cancers in the last year or 2 years is that we have a new generation of immunotherapies. Now we have immunotherapies that they go to the receptor, where the receptor of the cancer is. But instead of only blocking, because that's what we used to do before, and even in breast cancer, that's what they do. The breast cancer has a gene called HER2, and everybody in the world knows that there is a drug called Herceptin that goes to the receptor. It's a protein that blocks the receptor and cures tons of people, or even if it doesn't cure you, keep you alive.
Right.
But in lung cancer, as we told you, seems that it's not enough to only block the receptor with the protein. So this new generation of drugs block the receptor, but they carry a smart bomb. They carry a smart bomb of chemo. So it's very funny. We develop these oral agents and immunotherapy so we can get rid of chemo. We don't want to use chemo. But now we have found that chemo is extremely successful when we blew out the tumor, but we don't damage the patient. So the best way to do it now is this generation called antibody drug conjugates, ADCs.
Mhm.
These are antibodies, proteins, that they're going to reach the receptor first for the tumor, and then they release that small smart bomb that each antibody carries one bomb, and or two bombs or three bombs, but the chemo bombs get only released when they reach the receptor. So there is no risk for your hair or for your skin or for your stomach to have
Right.
side effects because it's very accurate. You know, it's a precision medicine again. These agents are amazing because they work not only for lung cancer, they work for many other cancers. Actually, I think there is already one approved for breast cancer. And
Mhm.
soon we already have one approved for lung cancer. And that is why this is a new generation of drugs. So hopefully, if the patients don't do well with our immunotherapy, this gives another line of defense for our patient. And as I said, because it's a type of drug, it's not only one pharmaceutical company. Each pharmaceutical company has this mini chemo. So we have a lot of these different drugs that can be used, a lot of different receptors. So that's why there is a lot of hope, a lot of excitement, not only for lung cancer, but also for other cancers with these antibody drug conjugates, ADCs. This is the most exciting thing. I also want to tell the public that most of the solid tumors, including lung cancer, bone marrow transplants or any transplant doesn't work for us. You know, these tumors don't, because this is the most popular question. You know, we cure now people with leukemia, lymphoma, myeloma,
Right.
bone marrow transplants, and the new types of transplants called CAR-Ts. This is very exciting, but
Yeah.
doesn't work for lung cancer. That's why it's not in that way that we are going to, I think, find the cure for lung cancer. But we're very fortunate that we have other ways, as I was explaining you.
Excellent. And so, these are all examples of research, and we find these new treatments and advanced treatments through clinical trials. So, what would be your advice to a patient who is diagnosed with cancer, regarding clinical trials? Is that something that you would tell them to talk about, to ask about? What advice do you give patients about that?
Yeah, this is a very difficult conversation because lung cancer is ranked number 3 in lethality. You know, unfortunately, I think we still have that after pancreas cancer and melanoma.
Mhm.
This is the third one that kills more people. You know, as I told you, with chemotherapy, we were only able to save 5% of the advanced ones, and maybe another 15% of the people that had early stage. So the lethality of lung cancer was like 85%. So horrible. Now, thanks to all of these technologies that we have described, our lethality is going down, but we're still above 50%.
Right.
You know, for sure. Because a lot of the modalities I mentioned to you are only keeping the people alive, but we're not curing people yet. So that is why it's a difficult conversation, but I think it's important to be honest with the patient from day one, because they need to know that they need to prepare himself, herself, or his family, because there is a chance that he may not get cured. And also the other important thing for us is to keep a very good quality of life. If it's going to be 3 years, 4 years, we really want that meaningful years. We want them to go for vacation. We want them to spend time with the loved ones and trying to minimize time in the hospital or things like that. That's why the therapies I described, the target therapy with oral agents and the immunotherapy, are not very toxic for more than 90% of the patients. The target therapy, you take the pills at home. The immunotherapy, you have to come every 3 or 4 weeks. But that's a small inconvenience because the rest of the time is yours.
Right.
And like I said, more than 90% of the time, the toxicity is minimal. to the point that unfortunately there is some young people with lung cancer and they cannot retire yet, they need to work. So they are working full time, but they are still having the immunotherapy and the target therapy because most of the side effects are very tolerable and they can still have a good quality of life. But we tell all of these things to the patients when they want, because unfortunately there is nobody after us. You know, we as oncologists, we learn that the primary care feels very uncomfortable talking about this. The pulmonologist feel uncomfortable. The surgeon gives the bad news that your cancer is inoperable, but he's not going to be with you the next 3 years. So he doesn't have the responsibility to talk about this issue with you. That's why there is nobody coming after us. So that's why we really and we really like to give a lot of hope, because really sometimes said, but you know, why are you giving me hope if you're going to live 3 years? Because I tell you, because we research so many new drugs that maybe 3 years is the bridge that I need, because in 3 years I'll find something that keep you alive for years, or something that may cure you.
Right.
That's why, because that's the honest truth. When you see the patients in day one, when they are new, you don't really know exactly who is going to get cured or no. There is statistics, but you don't really know. That's why you really have hope. For example, so for all of these reasons, I have I think it's very important that the patient knows from day one, for everything that we have discussed in this interview. That's why I think we really need to empower the patients so they are very aware about their treatment options, and they can decide. You know, some people may be very willing to be treated aggressively. Some people may prefer to be more conservative, and we always need to respect. You know, the same as the stigma. You know, we love our patients. If you smoke or don't smoke, you know, nobody judges you, and I think these type of judgments have damaged a lot, you know, the cause, and has not been in the best interest of the patient. But I think engaging the patients now, thanks to these interviews and information that you guys provide, is the best thing that we to do to help them, other than treatment. You know?
Absolutely. And that's key. The patient should be well informed, you know, reaching out to their doctors, talking with you during their visits, and they can learn so much from you as we have today. So I thank you so much for your time, and we appreciate, you know, everything that you're doing for patients. So thank you so much.
No, again, I want to give thanks to Massive Bio, because, you know, this is very important. We really want to advertise. We need your help, and I'm talking about the audience, and we want please promote lung cancer screening. You know, we're so lucky in the United States that it's even covered by insurance. And a lot of cancer centers like mine, if you don't have insurance, for $90, we do that once a year.
Oh, that's amazing.
Yeah, you can do once a year. We need also to advertise the fact that please don't smoke anymore. And once that you have lung cancer, please, molecular testing, push hard for molecular testing. I already told you, it makes a big difference.
Yeah.
You need to require your doctor to do molecular testing before to treat you, and have a lot of hope. As we discussed in research, we have now the target therapies, we have the immunotherapy, and thanks to that, patients are living longer. There is a type, for example, of lung cancer called ALK. This type of ALK people, even if it's metastatic, the patients now live as an average of 8 years. So there is a lot of hope now for them. Unfortunately, with other types of lung cancer, maybe it's not 8 years, but as I said, you never lose hope, because maybe in the next 6 months or 1 year, the FDA will approve the next drug that can give you 8 years. So thank you very much for the interview. I'm more than happy to share with you in the future.
Thank you so much. We appreciate you. And for everyone listening, of course, you can reach out to us, Massive Bio, our website, massivebio.com. We will help you with clinical trials, and we can help with connecting you to molecular testing, because it is so very important. So thanks again. Take care.
Thank you.
Bye-bye.
Bye-bye.